Hello, ladies and gentlemen. Thank you very much for the invitation and the possibility to talk about the very current and important topic of COVID and pregnancy. I'm Dr. Sabine Enengl. I'm Department Deputy Head of Obstetrics in Kepler University Hospital, and I'm happy to give you a quick insight about this topic. So I want to start with a few facts which are important to know. So the majority of women who are pregnant and are infected with coronavirus are asymptomatic or experience a mild course of the disease. It's about 70 to 89%. But we gain more and more data that these women are at a higher risk for the severe course of the disease than the non-pregnant patient collective. So talking about severe course of the disease, we talk about 15% of hospital admission due to literature, comparing to 5.8% in the non-pregnant patient collective. Of these stationary patients, even 5.7% have the need for intensive care unit treatment. This is an odds ratio of 1.6, so this is quite a high risk. In our COVID positive collective, we find higher rates of preterm deliveries. We have to say these are not spontaneous preterm deliveries, but deliveries which are induced by doctors because of the COVID disease. So the respiratory situation of a pregnant woman can possibly be influenced after delivery. You have to imagine a woman being pregnant, the diaphragm is like really high, which makes it even more difficult to breathe and things like that. So these preterm deliveries are due to the fact that we think it's possible to improve the COVID situation. We do also find more patients with preeclampsia who are COVID positive. Preeclampsia is a hypertensive disorder in pregnancy, which is caused by a damage of vessels in the early placentation period, so in early pregnancy, which can do much harm at the end of the pregnancy. Unfortunately, we do also gain more and more data that we have more fetal deaths in our COVID collective. We find odds ratios about 2.2. So this means that COVID positive ladies have twice the risk than non-COVID positive patients to have a fetal death. The question about vertical transmission is still unclear. Vertical transmission means the fact that a fetus is infected in utero by its mother. So this condition is described in a few case series and small case reports, but seems to be a real rare condition, but not totally excluded. So what is the treatment that our COVID pregnant patients get? Basically, we have to say it doesn't make any difference. It's the same treatment than the non-pregnant collective. So we have a symptomatic therapy from painkillers to cough syrups, for example. It's of course important to lower the body temperature, the fever. So we have antipyretic medication like paracetamol. Paracetamol is a medication that can be used during pregnancy without any great concern anyway. Of course, sometimes we do also have the need for oxygen supply. So the oxygen saturation should be at least above 92% in our pregnant women. We do also know that COVID patients have a higher risk for thrombosis. So this is why we're giving thrombosis prophylaxis to all our women. This is heparin most of the time. In some rare cases, we also give antibiotics. This is only necessary when there is a bacterial superinfection. And ladies suffering from a really critical disease or having extremely high need for oxygen supply also get cortisone in order to improve the respiratory situation. So what are the challenges in obstetrics? Of course, a COVID positive woman has to be isolated. but not only on the obstetric ward, which is not that dramatic, but also during delivery. And this makes things even more complicated. So pregnant women with COVID giving birth are not allowed to bring a companion. So they are isolated in the delivery room all by themselves. Of course, we have midwives caring for them, wearing protective clothing for more than several hours to make it possible to stay with the lady for this long time. In obstetrics, we have emergency situation which acquire the need for a doctor or which make it necessary to do quick interventions. And of course, this can be a really stressful situation if it's necessary to treat these patients as a doctors, to put on protective clothing really fast, to manage severe bleeding, to manage fetal heartbeat drops, to do emergency cesarean sections, to guarantee a quick transportation to the operation room. So this was a big learning curve for all of us to manage such extreme situations. I was already talking about preterm delivery. So the time of delivery is also a very individual decision. As I said, most of the patients, fortunately, are asymptomatic or only have a mild disease. So in these cases, we would just await the spontaneous delivery, like spontaneous beginning of contractions or rupture of membranes, for example. But in other cases, having severe diseases, to improve the respiratory situation, it can be necessary to decide if delivery would improve the situation. Of course, this decision always have to be in balance with the consequences of a preterm delivery for the fetus. If a preterm delivery is planned before 34 weeks of pregnancy, we at least try to administer fetal lung maturation. This is 2 injections of cortisone with an interval of 24 hours in order to improve the respiratory situation of the baby after birth. So I want to give you a quick insight about the data we collected at our clinic, at our department so far. So up to now, we had about 180 deliveries of patients who were COVID positive or already recovered at the time of their birth. Luckily, we only had 2 women who had the need for intensive care treatment so far. One woman really had a critical disease with the need for mechanical ventilation support. She had an emergency cesarean section at about 26 weeks of pregnancy, and unfortunately the baby did not make it because of severe intracerebral hemorrhage. The other lady, which was treated at ICU, just had a higher need of oxygen supply, which was not manageable at our standard obstetric ward. But luckily, she could be discharged a few days later, and she should be fine. She did not deliver until now. We're doing a prospective observational study, a multi-center study at our department at the moment. So far, it was possible to include 93 patients in our analysis. Our analysis focuses on antibody status of our women and antibody status in the cord blood of our babies. And I want to show you some of the data we collected so far. Comparing our COVID study group with our healthy control individuals, we interestingly do not find any significant differences in maternal comorbidities. So they don't have more diabetes or lung conditions like asthma or something you would probably suspect. 27 ladies of approximately 90 have been symptomatic at the time of delivery, 22 already have been negative, and 20 had a CT value below 30, which means that they were highly infectious during birth. In our collective, we did not find a really high rate of preterm delivery, namely only 11.8%. And this is just a representative rate for a big obstetric clinic like ours. The neonatal outcome in both groups was totally comparable, so there was no difference at all. Interestingly, we had a significantly higher rate of cesarean sections in our COVID group. This is, of course, explainable by the fact that at the beginning of the pandemic, as I told you before, we had to organize ourselves. We didn't want to get into much emergency situations. So if there was a slight complication, we recommended an early cesarean section in order to prevent a really stressful situation for the lady. But at the time, our cesarean rates in COVID Collective is getting lower and lower from week to week. So we have a big learning curve focusing on that. Interestingly, we had 3 babies who were tested positive for COVID right after birth via PCR testing. But we have to admit on the next day, all of the babies have been negative again. So maybe it was just due to contamination with maternal tissue. So I want to give you a quick overview on the antibody status of our patient collective. As you can see, we find 55 women with antibodies of the subclass IgA. These antibodies normally are positive when you have a current infection. We have 34 women having IgG antibodies. These are antibodies for immune status. And we do find 21 of our fetuses who had the IgG already in their umbilical cord blood. And this, of course, could be a very important mechanism for fetal protection. We're doing another big study at the moment in collaboration with a few clinics in Germany, and I can give you some of the preliminary results that we know at the moment that it takes approximately one week for the IgG antibodies to be transported from the mother to the baby via the cord blood. So this makes totally sense that not all of the babies had IgG in their cord blood, even though the mother was positive. I just want to give you the name of the Chronos study. This is the big study of many clinics in Germany. It's a big online database. You can see at the moment 118 big obstetric clinics give their data about pregnancy and COVID to this database. And so you have a really nice collection if you want to have a quick insight or if you have any questions. So let me end with a few words about vaccination, because this is a very important topic as well. If a couple or a lady is preparing for pregnancy, of course, a full course of vaccination is recommended. We don't have any special time interval that is recommended between the onset of pregnancy and the vaccination. However, some societies like the ESHRE, this is a European Society for Human Reproduction and Embryology, advises the women to at least have a few days between vaccination and reproductive treatment like IVF or ICSI, for example. If a vaccination takes place accidentally at the beginning of pregnancy, in early pregnancy, this is no need for an interruption because we have no data that this vaccination would do any harm to the fetus. We do also find no fertility impairment, not in women, not in men. So it's basically totally safe when you have the wish for a baby to get your vaccination done before. Some women experience irregular menstrual cycles for about 2 or 3 months after the vaccination, but I wouldn't be too concerned about that because these normally stabilize all by themselves and should not make a big problem. In the meantime, the Austrian Society for Obstetrics and Gynecology also advises women to have the vaccination or their booster vaccination done in pregnancy. We recommend to use the mRNA vaccine, Pfizer for example, because this is the vaccine type with the most research so far. We do have some studies about vaccination in pregnancy, and we find antibody reactions which are comparable to infected women. Of course, at the moment, it's still an off-label use because we have no official drug approval for this vaccination, but we hope that we will get it soon, as Pfizer is doing a really big study on 4,000 pregnant women at the moment. As the first weeks of the pregnancy are a very vulnerable phase with the highest risk for pregnancy complications or abortions, we would advise to do the vaccination in the second or in the third trimester, not to find any correlation, any possible correlation with the vaccination done in early pregnancy. There is also the strong recommendation to do boost or vaccination during breastfeeding period. We do also find antibodies in the breast milk, and interestingly, we do also find antibodies in the saliva of the babies. So these can be additional mechanisms of protections for the baby and could again improve the situation for our newborns. So with the strong recommendation for all the ladies listening and outside to do their vaccination done, I can close, and I'm happy to answer a few questions. Thank you very much.